Well, I think so. That's my next question. You're talking about Cleveland Clinic, where you have practice you've built with scopes, and you're doing 13 a day. I'm
Well,
a
the maximum. I don't want it to get out. I mean, on the
oh no,
average,
I
yeah, yeah.
gotcha. So I'm a MIG surgeon. I've been doing this for 13 years now. I've got an Endo C is what we've got, which is helpful. But I think most of us in our practices don't have access to that same setup that you've got. What I had in fellowship is not what I have in my current
Yeah.
practice.
Mm-hmm.
And so
Mm-hmm.
for most of our listeners, I guess the question would be not what can you see, but what is the benefit? Again, if someone comes in, screen with ultrasound, if there's an obvious focal lesion, I don't need to do the office biopsy. I know I've got to go in
Correct.
and take,
Correct.
and I'm not going to, so I actually do the ultrasound first because I don't want to do a blind biopsy, then get the ultrasound results. So now I've got to go back and hysteroscopy and take a polyp out or do myomectomy or whatever. I'll get the ultrasound first, hopefully same day if we can get it. And then if the ultrasound's normal, we can do the sample, rule out cancer, and then we have all the options in the world. I typically reserve visualized biopsy or hysteroscopy for folks that we've managed medically and failed in a setting of a normal ultrasound. And I guess what I would like to know is sort of why we should change that practice, not just because we can, but what
I'm
does the
not
data
saying that
show
you.
us?
I'm not saying that you should change what we know. In fact, we're working right now on a huge guidelines group. We meet every other Sunday. AAGL, ESG, several is an international group looking at just this question. I think what and that paper will be, hopefully the guideline paper will be out by the end of the year. Okay, beginning of the first quarter of 2026. It's not an either or. I like what you do. There's nothing wrong with it, okay? Because you are looking and then you're doing, and if the patient doesn't get better with your protocol, then you are going to go to hysteroscopy. You see what I'm saying? Or not going to just do something, a blind curettage. So I don't have a problem with that. And so
Yeah, I haven't done a blind DNC in, probably since residency. It's been a long time, 15 years.
but there are a lot of people that aren't like you, Mark. I'm just saying, you and I get to travel, we get to talk to people, and we get to see this continuation. In the 1960s, 80s, DNC was the biggest procedure. And some people have failed to learn about new technology and incorporate new technology into their practice. The learning curve for hysteroscopy, you ask everybody, this is what troubles me. You ask someone your age, my age, you go to a meeting, how many of you are doing robotic hysterectomies? Everybody and their brother and sister raise their hand. You ask the same question about hysteroscopy every meeting, at most a third. Maybe we can get up to 40%. How many of you are doing blah, blah, blah? Everything else people are learning, but hysteroscopy has just been, it's been underutilized. And for the life of me, I can't understand for being
There's
able to
nothing more
image.
fun or satisfying than a good hysteroscopic case, right? No skin to close, no one to round on the next day. Patients
Yes,
are happy. You've solved a problem. The true, initial natural orifice surgery, right?
right,
No,
right,
no.
yeah.
Clearly I think it's the thing I would say if I could get a practice like yours one of these days, I would like to do it now that I'm only 30% clinical. But I guess the question I would ask though is, so office biopsy versus, that's really the question here today is I know there's a group of you guys. I know I've talked to Nash Moad for years about this, and there's sort of this contingency of folks that say we should never be doing blinded biopsies because we have the technology to look. And I think it makes logical sense, but what does the data show us?
Oh, the data shows more accuracy with directed biopsy. So the thing is, if you look inside the uterus and you have diffuse disease, and meaning you just see thickened tissue, yellow, necrotic, bleeding, friability, and it's everywhere. And studies have been shown that if you put up just a pipelle in, yes, if that's diffuse hyperplasia, cancer, you're going to get it. What has been shown is that when you have the surface area, if it's less than 5%, you're going to miss a large amount, less than 25%. So it depends on the size of the lesion. So if I look in somebody's uterus and it is just filled with stuff, even if I didn't have a thickened, if she's postmenopause, thickened endometrium of 10 or 20, but it's everywhere, I know that it's very likely using pipelle, or we don't use Vabra anymore. But when you look up there and you see a focal lesion by the cornea or the fundus, you're just not going to get that. You see what I'm saying? You're going to miss it.
What do we miss? I mean, it's one thing to miss a benign polyp, right?
No, don't take it so lightly. If you're a woman and it's summer and I'm wearing white pants and golfing and I'm staining and I have to wear a mini pad every day, I wonder about after having sex, am I going to bleed, stain, or spot? See, I think we minimize a woman's symptoms.
No, I appreciate
so
that.
I will go to bat that it's not cancer, but it has changed your social dynamics. Asking, do you have a pad? Looking at the seat when you stand up, not wearing white. So I think any bleeding, no, it's not going to kill you. You don't have a hemoglobin of 2, but every blue moon you're bleeding when it's not your period or you're menopausal, and it's just you're worried about it. So I really want people to say, take it seriously. We're going to rule out cancer, and what you're going to miss are focal things. As I mentioned, 40 to 60% focal polyps and fibroids. There could be focal hyperplasia. Yes, you can have coexisting things, So I think what I'm saying is and I've done cases, postmenopausal woman, big, it's anecdotal, 2, 3, 4 centimeter myeloma, resected in the OR. Oh my God. And behind it is the cancer. I take it, I look at it, that fibroid was probably just present and a passenger. It wasn't the problem. The cancer was behind it, or it's up by the cornua. So, or you have a uterine anomaly and the cancer is on, you put your pipelle or your curette in and you're in the wrong part of the cavity. So I just think seeing is believing. You can't convince me that anything's better than looking. And I would say if it was your wife's sister, grandmother, someone, and it kept bleeding, I think you would want the doctor to look.